I thought it was just really amazing that as a doctor, I could help people who had what might be a devastating injury.
Welcome to eShadowing. My name is Dr. Ryan Gray. I am with Dr. Gayle Spill today. Physical medicine, rehabilitation, cancer rehab, and clinical ethics.
Oh my
Dr.
gosh,
Spill, thank you for
so
joining
many
me
things.
today.
You're very welcome. I'm happy to be here.
As you, the students, trickle in, go ahead and make sure that you turn your chat setting to everyone from host and panelists only. So change it to everyone, and then let us know where you are watching from. I love seeing where students are. And if you are interested in physiatry or physical medicine and rehabilitation, as it is known, or rehab medicine, or whatever, Dr. Spill and I were having a conversation about the name earlier. Angie from Arlington, Texas. Verinda from British Columbia, Canada. Marina from Sacramento. Awesome. Puerto Rico in the house. Dr. Gayle Spill, when did you first realize that physical medicine and rehabilitation was this specialty out there that you're like, ooh, that sounds cool. I want to do that?
So that's a really good question. So when I was in my second year of medical school, and this is before most of the people listening were even born, I went to they broke us up. My memory is a little fuzzy on this, but they broke us up into like these small groups, and we went to like different lectures or presentations. And the presentation I went to was by some people that were talking about vocational rehabilitation. And they, presented a story of a gentleman who was in construction, working on, high beams on skyscrapers, building buildings, and he suffered a brain injury and which affected his balance. But pretty much everything else was still intact. And so they worked with him to retrain him. So instead of being up in the buildings, doing the actual construction, he was now reading the plans and doing inspection. So they took all of his knowledge, they accommodated for his new disability, and they were able to get this gentleman back to work. And I thought that was so amazing. And I went up to the presenters afterwards and I said, is there any field of medicine that does this kind of thing? And they said, yeah, rehabilitation, PM&R. And I was like, okay, that's what I'm going to explore. And that's where it all started.
Interesting.
Yeah.
It seems like that angle of things, when I think a student pictures medicine, right, being in the hospital and taking care of patients and surgery and all of that, that seems like the exact opposite. What do you think it was about what that entailed that you were like, oh, I can take my medical knowledge and incorporate it into this thing that is needed?
Well, gosh, so long ago. I think I thought it was just really amazing that as a doctor, I could help people who had what might be a devastating injury find some meaning and continued quality of life.
Yeah.
And as I learned more and more about the specialty in medical school and then obviously in residency, that really appealed to me. In Judaism, there's a saying called tikkun olam, which is repairing the world. Mm-hmm. And I thought that this was a way of repairing the world, people who have spinal cord injuries or brain injuries or strokes, and helping them maximize their quality of life, despite what has happened to them. Does that make sense?
Yeah, it makes complete sense. And it's interesting to bring some religious aspect to it from Judaism. I was going to ask you if you had any, it sounded like just from that experience that you potentially had some experience, whether it's a family member or a friend who may have needed that, but the religious aspect also makes sense that you had some mindset of that.
Yeah, no, I never did, which is, a lot of people who go into rehab medicine, they have a family member who had a stroke or know somebody. I didn't, and I'm not a super religious person either, but that idea of repairing the world is one aspect of Judaism that has always appealed to me. And I'm, like I said, I'm not super religious,
Yeah,
but that idea, that tenet of Judaism, I think is something that we can all relate to. Like,
yeah.
what can we do to repair the world, even if it's just one person at a time or one little thing at a time?
One at a time. So
Yeah.
when you found this field, was there something else that you were like going down the path toward? Where did PM&R steal you away from OBGYN or another specialty that you thought you were going to do?
No, as I went through my clinicals, in medical school, I I didn't find the one thing that I really loved. I mean, surgery was kind of cool, but I really didn't like being in the OR. I didn't like that atmosphere. And this is back in the 90s where, surgeons were 98% male and they were not the nicest people. OBGYN, I was like, no. The only thing only other thing I was considering was pediatrics, because I love kids. But at the time, knowing that I was, someday wanting to have a family of my own, I thought about, gosh, would I want to leave my own kid if they were sick to go take care of someone else's sick kid? I don't know if I'd want to do that. Like,
Yeah.
that felt, I don't know. So I kind of was like, maybe pediatrics. But there was nothing else that I was like down the road to and then shifted. It was always from, once I found PM&R, every time I learned more and more about it, it reinforced that it was the right thing for me.
Yeah. Let's look at some of the technical side of things. What does PM&R residency look like? What is that path and years that are required for residency?
So it's, you do a general internship. Some people do like a transitional year. Some people just do a straight internal medicine year. And then it's a 3-year residency after that. So a total of 4 years of postgraduate training. In most programs, the first year is very heavily inpatient rehabilitation. So you are taking care of people that have been admitted to a rehabilitation hospital or rehabilitation center or wing or floor of a hospital, and doing inpatient rehabilitation. And what that entails is, as a resident, learning about the unique medical needs of people with various disabilities, and also managing their general medical problems and their pain and everything, and their psychological distress and everything else that's going on, so that then they can successfully participate in their rehabilitation.
Okay.
And then the years 2 and 3 are a mixture of a lot of outpatient medicine, consults in an acute care hospital, procedures, and things like that.
Yeah. And just a reminder for someone listening, years 2 and 3, you're referring to postgraduate year 3 and 4.
Correct.
All right. So
Correct.
so PM&R is one of those. There's still a few out there that require that prelim year before going into the actual specialty residency. So confusing for early pre-meds and med students to fully understand that part of the process.
Mm-hmm.
And then for you, right, when I introduced you, you have cancer rehabilitation as part of your kind of title and job. When did that kind of fall into your lap?
That fell into my lap further on in when I was a resident. My resident research was in cancer rehabilitation. So I worked with 2 other attendings and we did a chart review of patients who were admitted to the rehab hospital at the time, the Rehab Institute of Chicago, and looked at patients with cancer and did they make gains in rehabilitation? Because there's always been this idea, well, if you have cancer, you don't need rehab, you should just go home and be with your family or
go home and die.
You know,
It's like, no.
And so we did this retrospective chart review and published, and it was actually, it's now this is how old I am. It's now a classic article, right? Looking at, that patients with cancer, when they go to rehab, they can make gains, they can make functional gains, and they mostly get discharged home, and they do as well as people who are admitted to rehabilitation facilities for any other number of diagnoses. So that was where it started. And then in my first job after residency, I eventually ended up working at a small community hospital that had an active cancer program, and it re-piqued my interest in working with cancer patients. And trying to find ways to improve quality of life, even in the face of life-limiting illness. So because I found myself wanting to explore that more, I then did a fellowship in clinical medical ethics at the University of Chicago, so that I could just learn more about end-of-life care and the ethics that are involved with end-of-life care and complex decision-making. And then I was able to, I got recruited to come back to the Rehab Institute of Chicago to do cancer rehabilitation as my primary job. Now it's a more mixed, but we don't need to get into that. But so that's what I'm doing. And we can talk if you want. I can explain a little bit more about what I mean when I say cancer rehabilitation.
Yeah, no, I would love to dive into that. I do want to just backtrack just a tiny bit. What brought you into this field, right? The example that you gave of this person who had a brain injury and couldn't do the job that he was doing before, that's very different than what you ended up going into. Do you ever think about kind of that diverging path for you?
I'd say it was a diverging path because I did do brain injury and stroke and spinal cord injury and amputee medicine for a long time.
Okay.
And really, really enjoyed it. But as I continued in my career, I realized that having difficult conversations with patients and families was something that I wasn't afraid of.
Yeah.
And that I was potentially good at.
Which is rare, I think, among physicians. I think that is an amazing skill that you have that you knew about. And so you probably were the one that's like, oh, go get Dr. Spill. And you're like, okay, how do I do more of this?
Yes, that did happen.
Yeah.
And so I think we all gravitate towards things that we're good at.
Yeah.
And so, seeing that and sort of enjoying that ability to have those hard conversations is what sort of took me down the road of cancer rehabilitation. So there you go.
Yeah. Okay. Yeah. No, that's awesome. And just for the timeline, how far into or how many years after your residency did you jump into the fellowship?
I finished residency in I graduated high school in 92. I finished residency in 94, and I didn't do the ethics fellowship till 2005, the year that the Chicago White Sox won the World Series. So that's
nice.
Good year. Yeah.
That was a good year. I'm a White Sox fan, so that's a good year.
Excellent.
Okay, so there was some time where you were doing lots of different things, and then you found this passion. Okay, so yeah, let's dive into what exactly is cancer rehab and what does that look like?
So So let's, if you don't mind, let's back up a little bit and
Yeah.
talk about what is physical medicine and rehabilitation
Let's do it.
more broadly, right?
Yep.
So the specialty in and of itself has a lot of components, right? So there's people that do like, sometimes I think of it as the physical medicine part is like a lot of musculoskeletal medicine, sports medicine, pain management, a lot of outpatient stuff. People do ultrasound and injections and procedures. And then there's sort of more the rehabilitation side of it, which is working with people who have had things like strokes and brain injuries and spinal cord injuries and amputations and burns and neuromuscular disorders and things like that. So that's kind of a broad look at what PM&R is in general, with the thing that brings it all together is a focus on function, right? If we're going to try and treat your pain, we're going to do it with a goal of making you more functional. So that's PM&R sort of in a nutshell. And then if you look at cancer rehabilitation, it's kind of just like a microcosm of all of those things, because we have cancer patients who have brain tumors, and their rehab looks the same as someone who has a brain injury or stroke. We have cancer patients who have spinal cord tumors, and their rehab looks very similar to someone who has had a traumatic spinal cord injury. We have patients who have neuropathies from their chemotherapy. We have patients who have musculoskeletal problems from their radiation. We have breast cancer patients who have had a mastectomy and can't move their shoulder because they're so sore, but they need to be able to get their arm over their head for their radiation. So that's, not that dissimilar to someone who has a frozen shoulder from, playing too much tennis. So it's kind of all the things that we do in general, but in the cancer population, with the added complexity of what's coming next with their cancer. What's the next treatment? Is the cancer progressing? Is the cancer stable? Is the cancer in remission? And how do we take that all into account as we're developing a rehabilitation plan for this patient?
So if I were a layperson listening to this and trying to understand where this fits in the world of medicine, one potential question that I see that may be common is, why wouldn't an oncologist working with a physical therapist do this type of stuff? Where does that specialty training really help the patient at the end of the day?
So oncologists don't generally know how to prescribe physical therapy. The issues.
But I want to pause on that real quick, right? Because I think it's a very interesting thing that you just said, prescribe physical therapy. What I think a lot of students don't understand is that you don't just say as the physician, right, go do physical therapy, the physical therapist will figure it out, right?
Well, a lot of physicians do that.
They do. They shouldn't.
Right.
Yes. Yeah. You are actually helping the physical therapist go, here's exactly what I need, not go see that person, they'll figure it out. Right.
I liken it to, you don't give a patient a prescription for blood pressure medicine.
Yeah.
Right.
And the pharmacist will figure it out. Yeah.
Right. The pharmacist will figure it out. It's kind of the same thing. Now, there's a lot of really, really, really good physical therapists,
of course,
who are very experienced and can figure it out. But the physical therapist doesn't necessarily know that we can't, this patient who has a shoulder problem, let's say after breast cancer surgery, has to, what the goals are. I have to tell them, this patient needs to be able to get their arm up over their head so they can go through their radiation. And this is the time frame we have to do it in. And these are the things that you need to watch out for, right? Mm-hmm. Because if you see that, there's skin damage, that there's scarring, if you see this, that, or the other thing, that's a problem. We need to know about it. So I have to make sure that we're not causing any damage while we're trying to get to our goal. The physical therapists, one of the things that I see a lot, because I work in the acute care hospital side of it, is that the physical therapists and the occupational therapists don't have an understanding of how the progression of the disease and the treatment of the disease and the prognosis of the disease and how the different medications that the patient is on, the chemotherapy agents, can affect their function. So the therapists sometimes see a patient in the acute care hospital and say, oh, this patient should go to a rehab hospital. And then I go see the patient and I see that they have a cachexia score of 4 and that their disease has progressed through 3 or 4 treatments of chemotherapy, and that they're, declining very quickly. And at that point, it's my job to say, no, your disease is progressing faster than rehab can. And all the physical therapist is looking at is, well, 2 weeks ago, the patient could do this and now they can't, therefore they need rehab. But there's so many nuances to that the therapists don't know. They're very good at their jobs.
Yep.
But there's a lot more to it than that.
Yeah, that makes sense. We have a question from a student here that asks, for a cancer rehab patient, do you try to be direct and honest about their chance of recovery, or do you try to suggest, or do you try to sugarcoat it so that they still have hope and motivation to keep on improving? But what's that balance between quote unquote honesty, truth, and a little bit of silver lining?
Do you have another 2 weeks to discuss that?
Yeah.
So I really, really try to do a little bit of both. I don't think I ever sugarcoat things, because I don't think that helps anybody. And sometimes I think the most important thing I can do is tell somebody when I can't help them, because it may help them move on. So can I share a patient story?
I love it.
So I had this patient that I was following. He was admitted to the oncology service, and he had severe pain from his cancer in his hip. And he, every time the therapist tried to work with him, he was in a lot of pain. And then when we tried to give him enough pain medication, then he got kind of loopy. And he also, really wanted to be able to go home. So we ended up having a meeting, a family team meeting. It was me and the palliative medicine specialist and the patient and his family and the oncology team. And he said that his 3 goals were to be not in pain, to be able to walk, and to be able to go home. To be able to walk, to not be in pain, and to be cognitively intact. He did not want to be loopy. That was really important to him. And so I said to him, well, Mr. Smith, if you had to pick 2 of those, because I don't think we can do all 3, which 2 would you pick? And he said, I'd want to not be in pain, and I'd want to be cognitively intact. And then I was able to say, if those are the 2 that you would choose, I don't think we can control your pain enough for you to be cognitively intact and still be able to walk.
Yeah.
So I think that there's probably no role for rehabilitation here.
Yeah.
Let's just get you comfortable and get you home with your brain intact enough to continue to interact with your family in the way that you want to. And that's what he did. Does that help answer the question?
Yeah, I think so. How important, so a softball question, I think, how important do you think it is, or maybe I'll ask a more pointed question. How much do you think as physicians we miss that opportunity to ask for the patient's input on what they want, right? We as physicians, right, it's like, oh, cancer, let's beat it. Oh, rehab, let's get you back walking to a quote unquote typical, right, life of activities of daily living. And you have two legs, you should be able to walk. That's what I'm going to get you to, right? And how important and do you think it is for us to go, wait a minute, like let's take the patient's needs and wants into account here?
Well, obviously it's super important. And I don't think we do it enough.
Yeah.
So um,
Where is that opportunity?
well, you have to look for it, right? And you have to make it, right? You have to be the one to, some patients are really good at it and some are not, you know? And you also have to be willing to admit that you may not be able to give them what they want, or that it's a long shot, if you want to sugarcoat it, So another just really quick vignette. So I had this was back when I was still doing more general rehab. I had a stroke patient come to see me in my outpatient clinic, and she had an aphasia, meaning she had damage to the left side of her brain and had difficulty speaking, but she could understand everything. And she had a right hemiplegia, so severe weakness in her right arm and right leg. And so her husband was with her, and he was doing most of the talking for her. And he said, we need to get her walking. She needs to be able to dress herself, blah, blah, blah. And I looked at her and I said, let's pretend I have a magic pen here. If I could use my magic pen to either fix your speech, your arm, or your leg, which would you choose? And she immediately went to her mouth to fix her speech. And her husband was like, well, don't you want to walk? And she did this again.
Yeah.
And so long story short, I got her into a intensive speech therapy program. And 8 years later, I got a letter from her and her husband saying, dear Dr. Spill, we'll never forget you and your magic pen. You set us on the road that changed our lives forever. She's now still doing therapy remotely. She's riding horses in a therapeutic way in Florida. But the fact that they remembered the magic pen, that I took the time to ask her what she wanted, was amazing to me. I mean, I just, it blew my mind to get that letter 8 years later.
It's powerful.
I always tell residents, therapists, nurses, when you're talking to patients about their goals, sometimes they don't know how to say what they need or what they want. And so it's our job to ask the next question, right? That's the advice I always give. Ask the next question. So if a patient says, so if I say to a patient, what are your goals for rehabilitation? And they say, oh, I want to be better. What do you mean by better?
Yeah.
Or I want to walk. Where do you want to go? Right? And you'd be surprised at what you hear. So you have to be willing to take the time to ask the next questions, because a patient may say, I want to walk. When you say, where do you want to go? They say, well, I just want to be able to get to the bathroom. Yeah. Oh, okay. Well, your legs are really weak, and I'm really worried that it's going to be hard for you to walk to the bathroom. What if your husband took you to the bathroom in a wheelchair and then just assisted you to get onto the toilet? Oh, that would be fine. I just don't want to have to pee in the bed, right?
Yeah.
So we went from, I want to walk, to, I just want to be able to use the toilet, right? And from a goal that was maybe not doable to a goal that was very doable. Does that make sense? I hope I'm not talking too much above the students' heads.
No, I love it, because what you're talking about, I think at the end of the day, really has nothing to do about medicine. And it just has to do with basic human communication and trying to understand people, right? Which I think we don't do enough in medicine because we're so wrapped up, right? We have so many things to do.
Right.
And it's like, let's slow down for a second. And I like that. There's a book out there. It's more business oriented, but like, what's the question behind the question,
Mhm.
is kind of that kind of language. So I love it. I think it's great. What does a day in the life look like for you now as a cancer rehab specialist?
There's so many questions coming up in the chat. That's very
Yeah.
exciting. So for me, a lot of cancer rehab doctors do mostly outpatient medicine. Some do inpatient medicine. I do, my primary job is consults at the acute care hospital. So my day is seeing patients who have been admitted to, am I allowed to say the hospital name?
Sure.
Yeah, Northwestern Memorial Hospital here in Chicago,
Mhm.
and do assessments for what their rehabilitation needs are, which sometimes is go home and do outpatient therapy, go home and do home therapy, come to inpatient rehab, and sometimes it's, nothing. There's no, we can't help you at this point. So that's my job. And to try and figure out a rehab plan to help maximize the patient's function within the limits of their disease and the treatment of their disease. So if there's a patient who needs chemotherapy every week or every 2 weeks, I'm not going to suggest that they go to a rehab facility for 4 weeks and miss 2 cancer treatments.
Yeah.
So, working that in, and then also making recommendations about how to minimize the loss of function while the patients are in the hospital. So, just very simple things like, why aren't you getting this patient out of bed? And, if you have a patient who has weakness on the left side or the right side, make sure, and then I walk in the room, they can't use their right arm, and where's their call light? It's over on the right side of their bed, right? Just like simple things like that. How do I always talk to the residents about how do we make a difference in this patient's care right now?
Yeah.
What can we do right now to make a difference in this patient's care?
Yeah.
Pain management, spasticity management, things like that.
Jerry asked a question that I think is important, and you mentioned kind of a little bit already with the magic pen with this patient. The spouse said, "Don't you want to walk?" And the patient's like, "I want to be able to talk." Right?
Yeah.
How much of your care is managing family expectations as well?
A lot. Especially I find in cancer, there's a lot of times when the patients are just exhausted and they really, really don't want to do anything more. And the families are just pushing, don't give up. Come on. You're a fighter. You're this, you're that. And so, a conversation that I often have with patients and their families before they come to as an inpatient to rehab is, talking about what the goal is. And I never talk about, walking again. I never talk about this. I always say our goal is a safe discharge home, right? That's our goal, is to get you home safely. I don't know if you're going to be able to do this again or that again. We're going to try and get you as functional as possible. And what you can't do for yourself, we're going to train your family how to help you with safely. So a safe discharge home. And if I have a family member who says to me, well, I have to go to work, he has to be able to walk, blah, 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 before he can come home, then I have to have a conversation with them about, how likely that may or may not happen. And I have a whole bunch of I call them back pocket phrases and things that I've used and developed over the years to help people understand, and manage their expectations. And so that's a huge part. And families are often the biggest barrier to a patient transitioning to comfort care when they really should.
Yeah. We've had lots of advances in cancer therapeutics over the last couple decades. I just saw some early data, or at least the headlines on some early data about, I think it was pancreatic cancer. So post-surgical treatment, they took the actual cancer post-surgery, made an mRNA vaccine specific to that patient's cancer, and then administered the vaccine, and the quote unquote cancer-free rates were, I think it was like 8 months or 18 months or whatever it was. Like the patient was better versus having recurrence,
Here,
which
oh
is
yes, I think it was skin
expected.
cancer. I saw it on the news. Someone is saying.
Nice. Yeah, no, the one I'm talking about is specifically pancreatic cancer, because
Yeah.
I've family members and friends going through it right now.
Yeah.
And so that it stood out to me. How much do you think your job has changed over the last couple decades as you've been in it because of cancer therapy and the advances that are made on the medicine side?
So I think patients are obviously living longer. There's certain cancers like glioblastoma, which is a brain cancer. It used to be, you got a glioblastoma and you were dead in 6 months. Now I see patients living years and years with good quality of life. So, helping, those patients continue to be functional. I mean, whereas before it was absolutely 100% a death sentence, has been remarkable to see patients do really well. I've also had to keep up with, as the therapeutics change, they all have their side effects. So everybody talks about the immunotherapies and how effective they are, and immunotherapy this and immunotherapy that. But they don't tell you, but that you can also get like neurotoxicity from immunotherapies. And I've seen patients do very, very, have horrible side effects from immunotherapies.
Yeah.
That then they need rehab from the immunotherapy side effects. So keeping up with that and being aware of what what we have to offer, and also, trying to stay abreast, not as much as an oncologist, of the changes, so that, if, again, an example is like a glioblastoma, I'm going to offer rehab to that patient, as long as they can participate, and I think they can make some gains, even if it's their third recurrence, because I know that the treatments are so much better than they used to be. So, that's how it's changed. And people just living longer.
Yeah.
And therefore living with more disability.
You just mentioned something that kind of triggered a question. You mentioned you'll keep doing rehab as long as you can assume some gains. When do you think a lack of loss is just as important as a gain in function? If that question makes sense, right? The positive meaning you're not losing.
Maintenance therapy.
Maintenance, yeah.
I think if someone's got stable disease or is in remission, that's really important. But if someone's disease is progressing, it's not possible.
Yeah. Okay. You mentioned it briefly there about kind of, you probably won't know as much as an oncologist. How much oncology training did you get going through all of your residency, fellowship, and what you do now?
Zero.
Yeah. So are you plugged into you have an oncologist on speed dial? Is it a multidisciplinary team that you're working with? What does that look like?
So I know a lot of the oncologists. I know a lot of the hospitalists that work on the oncology floors. And if I have questions, I can call them. I also make really healthy use of a website called chemocare.com, which was started by Scott Hamilton, the ice skater, which is meant to be for patients and families, but it's great for rehab doctors too, which, goes through lists all the different chemotherapy and immunotherapy agents and what their side effects are and how they're dosed and how often they're generally given. And so that's really helpful for me. So if I'm seeing a patient who's getting Folfox, I'll be like, oh, wait, what's Folfox again? And I can go on chemocare.com, look up what Folfox is, look up the different medications, and then, so that's helpful. Dr. Google is also very, very helpful.
Yep. Yeah. Okay.
Yeah.
Karina asks a very interesting question. She says, they say, I'm starting to have the perspective that some specialties focus more on the quote whole person than others, which focus more on depth in a specific organ system. They ask, is that a fair perspective? And what other specialties do you think are oriented to the quote whole person?
None as much as rehabilitation. We're the
You're not
best.
biased or anything.
Not at all. So I think, to be honest, I think that any good doctor is focused on the whole person, regardless
Amen.
of the specialty.
Yep.
You know, the specialties that are considered more holistic are rehabilitation, palliative medicine, family medicine, things like that, I think are the ones that are sort of billed as focusing on the whole person. But if you're an orthopedic surgeon and you operate on a patient without knowing that their goal is to go back to marathon running, and that's really important to them, and you do something to their knee, which makes it so that they're not going to be able to run again, then you're a terrible doctor. I don't care how successful the surgery is.
Yep.
So I think all of us should be focused on the patient as a whole person. So to answer your question.
I love that. I had a fun argument with, I think he's former president of the American Osteopathic Association. And the osteopathic world has marketed itself as the holistic career field. And I argue with them. I'm like, it's the same argument you made, right? All good physicians treat patients holistically. He goes, yes. And I think osteopaths just do a little bit of a better job introducing that in medical school. I'm like, okay, I don't know, but I'll take that.
Sure.
I had an amazing question I was going to ask you, and I just lost it. When you look at your job, how much do you think you're bordering on rehab medicine, cancer rehab, versus palliative care, hospice type medicine? Where does that line end for you, or is there a blur?
So I want to just really be really clear for the students. My job, what I do in particular, there is definitely like a palliative end of life component to it for some patients, not all. But I don't want them to think that that's what all cancer rehab doctors do. Most rehab doctors who specialize in cancer work in the outpatient side of cancer rehab and do a lot of like survivorship issues and musculoskeletal issues for patients who are going through treatment or who are survivors and in remission. That is what most. So I don't want to scare people off from thinking about rehabilitation medicine or cancer rehab as a potential option for them if they don't like end of life care, because my area of interest in cancer rehabilitation and the job that I do has more of that than most people who do cancer rehabilitation. So for me, it's, you know, a lot of the patients that I'm seeing in consult, palliative medicine is also seeing in consult. And it's not uncommon for me to recommend a palliative medicine consult or for palliative to recommend a rehab consult. So, you know, we share a lot of the same patients. And again, that's because I'm seeing patients in the hospital, and most cancer patients are not in the hospital. Most cancer patients are out in the world. You know, you wouldn't even know that they have cancer. They're, you know, doing everything that they normally do. You see them on TV all the time, right?
Yeah.
You know, going to picnics and going to the store and doing pottery and things like that. So that's.
Yeah, got it. Good distinction there. For students, if you want to raise your hand, I can allow you to unmute and ask questions of Dr. Spill while we're here together for the next few minutes. Karina asked another interesting question, kind of related to the palliative care side of thing, the interest that you've taken in this world. What have you learned about what patients need most in that time? of their life?
Support, understanding, and people to listen to them, not just their doctors, but their families. So that when they say they're tired and they're done, that people listen to that. And I don't think we or sometimes families do that well enough. Just because we can do more doesn't mean we ought to. I think that's what we can do. And I think being really honest with patients about what we're offering can and can't do, right? I can't, someone who's had, I'll try and tell you another brief story. The medical student that shadowed me today, she said, tell stories. They like stories. I had this patient who had a glioblastoma, brain tumor, who was a master bird carver, right? Like he was an award-winning carving wooden birds,
Wow.
and this was his passion. And, after the first time his cancer, he had his initial cancer, he was, he had a really good recovery. He went back to bird carving. And then I saw him, maybe the third or fourth time that his cancer came back, he was going to do this very experimental treatment. And, his wife was just distraught because she was like, he thinks he's going to be able to go back to bird carving, and he's not. And I said, no, he's not. And she was so upset that the neuro-oncologist and the neurosurgeon, nobody had made it clear to him that this is not going to get you what you want.
Yeah.
And here he was about to undergo a fourth or fifth brain surgery and not get to where he wanted to be. And so just really being honest with patients and their families about, we can offer this, but it may not get you what you want. It may get you close, it maybe get you some of the things you want, but it may not get you what you want, which is why it's so important to figure out what they want.
Yeah. Yeah, I'm a huge technology nerd, and I think about the future of virtual reality, augmented reality, and maybe for this patient, right? Maybe they're not interacting specifically with wood and their tools, but maybe in a virtual world they can still do what they that art, that craft, but in a virtual world, and it kind of gives them some ability to stay
That would be
involved
amazing,
there.
wouldn't it?
Yeah. It looks like the student that was with you today is also on with us. So they say hi,
Okay.
Rachel.
Hi, Rachel.
Jerry, hello. You have a question?
Yeah, I put it in the chat, but I just wanted
Yeah.
to ask specifically when you were talking about survivorship issues, does that also include like the survivor's mental health? And so I wanted to ask if you are also in close contacts with a lot of therapists to essentially help a survivor.
Yeah, so I mean, one of the things that we could recommend, so if we see a patient and we say, in terms of survivorship issues, one of the biggest issues is fatigue. And that has all sorts of reasons for it. One of them may be depression, one of them may be poor sleep, which may be tied into depression, which may be, part of poor nutrition or, any of those things. So we may, I may refer a patient to a psychologist or a therapist to help manage the depression or the anxiety that they're feeling, and at the same time prescribe something to help them with their sleep, to try and manage that fatigue. So, that, for example, that would be something where I would potentially pull in other team members to help that patient with an issue like fatigue, which is one of the most prevalent survivorship issues for people with cancer. Fatigue, anxiety, there's always an anxiety about, is the cancer going to come back? Is the cancer going to come back?
Mm-hmm.
So.
Yeah, good question, Jerry. Thanks. How much of that's not the right way to frame it. It sounds like your job as part neurologist, part oncologist, part family medicine, part therapist, part
Mhm.
orthopedics, right?
Yeah,
It's a lot of things that you're doing and juggling from a specialty standpoint.
it is. I mean, probably mostly neurology and family medicine, but from a, kind of from a different bent,
Yeah.
like again, the focus on function. So, you know, I have the luxury of working in an academic medical center, so I can call a neurosurgeon or call an orthopedic surgeon or call an oncologist at any time and say, hey, I have this patient with this, that, or the other thing. What's their prognosis? What can we expect? So that I can then, get more information about the rehab, how to formulate a rehab plan for that patient.
Yeah.
So, which is nice. So I don't have to know everything because I have other people that do.
Yeah. Karina.
Hi, Dr. Spill. Thanks for
Hi.
being with us today.
Yeah.
I was going to ask you if you're willing to share about a time you made a mistake in caring for a patient, but then I thought, in case you don't want to answer that, I'm also wondering, alternatively, has there been any interesting ways that some of the standard of care has changed and you think, wow, 20 years ago we used to do X. I can't believe we did X. Now we do Y.
That's
Well,
the whole bedbound orthopedic world.
yeah, I mean, again, like for glioblastomas, it used to be, okay, you're going to die in 6 months, get your affairs in order, and now it's not. So, but in rehab, we have, research that has shown the benefit of different kinds of therapies for stroke that are now being incorporated and things like that weren't available. The technology that is available now that wasn't available 20 years ago. Honestly, I think the pandemic was, please don't take this the wrong way, potentially one of the best things that ever happened for disabled people. Because it used to be, oh, well, we can't make these accommodations. You can't work remotely. You can't go to school remotely. It's not going to work. And now all of a sudden it's like, well, we did it for everybody else. Why can't we continue to do it for people with disabilities, right?
Yeah.
Telemedicine was not a thing, and now it's a thing. So someone who lives 2 hours from my hospital and just needs to see their doctor to get a refill on their spasticity medication doesn't have to pay $400 for transportation to come see their physician. They can do a telemedicine visit. So for people with disabilities, the pandemic has really, I think, opened everybody's eyes to the things we can do to accommodate people.
Yeah, that's huge. I get mad in the world that I'm in. I'm getting mad at medical schools that have continued to say we will not accept online credits, right? Online courses.
Yeah.
I'm like, you taught medical school online, right?
Yeah.
You did just fine teaching. I'm like, they can learn chemistry online. What's the problem? Anyway.
Yeah.
Rachel asked an interesting question about kind of going back to what we were talking about with the pace of change in the pharmaceutical world and therapeutics for cancer. How much are you purposefully trying to stay on top of that? Or is it a case-by-case basis where a patient comes and they're on a new therapeutic, you're going and doing the research for that at the time?
Case by case. I can't possibly
Yeah.
keep up with it all. I
Yeah.
can't. I mean, I don't think, an oncologist who specializes in breast cancer is keeping up with what's going on for lung cancer. I mean, I just can't. It's not possible. So really case by case and looking things up as I need to.
Yeah. I think the current data suggests our medical knowledge is doubling every 60 or 90 days now, which is just incredible.
Yeah. I'm lucky. I know I'm lucky. I know how to find, if I can find the answer, I'm good.
Yeah. Yeah. We call that just in time learning, right? I learned it just in time to use it as I needed it.
Mm-hmm.
Well, Dr. Spill, thank you so much for taking some time. Any last minute words of wisdom for a student learning about physical medicine, rehabilitation, learning about cancer rehab today to go out and explore some more?
Yeah, I think I would say rehabilitation medicine is the best field, because, you know, when we see patients who have had horrible things happen to them, all the other doctors, you know, in the acute care hospital, they save your life. We send you home. And it's just so rewarding to be able to do that. I could tell stories for hours about that, you know, being able to send a patient home, you know, after they've been through horrible trauma. So definitely think about rehab as a field, explore it, but make sure you explore it. I did have a resident once a long time ago who was in radiology, didn't like that. So a friend said, "Oh, you should go to rehab. It's great. It's great. Come to our rehab residency." And he did, and he left after a year because he said, "Oh, I found out I really didn't like working with disabled people." So, you know, probably should make sure that whatever field you're going into, you're comfortable with the population. You know, if you don't like old people, don't go into geriatrics. If
I think
you don't
that's
like disabled,
smart.
if disabled people make you uncomfortable, don't go into rehab medicine. You know, if you don't like being peed on and pooped on, don't go into peds. So just know yourself well enough to figure out what's going to make sense for you.
Awesome. Thank you so much, everyone that came live. Thank you for some great questions. Dr. Gayle Spill, again, thank you so much for joining us today.
Thank you. Thank you for inviting me.